York viene Millhorat o bolognese? Millhorat. Dopo la presentazione di Millhorat invito i tre relatori qui per una discussione comune.
Thank you, and good afternoon. I'm going to continue the experience we've had with tethered cord syndrome, and I'm not going to repeat necessarily the things that were talked about this morning. This will be the outcome of 318 patients in whom we have carried out section of final terminality. All of these patients had a peculiar type of Chiari malformation. They met the criteria for Chiari, tonsillar herniation 5 millimeters or greater, but they had normal posterior cranial fossa size, normal posterior cranial fossa volume, a large foramen magnum, elongation, and downward displacement of the brainstem. They had all of those features in common. The ones that came to surgery all had indications that we use for surgery. That is to say, they had a propagating syrinx, they had a change in neurological function, deterioration of function, or they had a Karnofsky score of less than 70. So we look at these patients. There were 74 children and 244 adults. They tended to present with symptoms of both conditions, although the symptoms of Chiari were the things that had prompted their admission and their workup. And the symptoms and signs related to tethered cord syndrome tended to be minor in most instances. The diagnostic findings are here. You can see that there was a small share of patients that might be regarded as Chiari 0. We define minimal tonsillar herniation as 5 to 7 millimeters, and greater than 8 was just a standard Chiari malformation. There was an associated terminal syrinx here in 31% of children, 22% of adults. There was thoracolumbar, cervicothoracic syringomyelia, and holocord syrinx in a substantial number of both patients. There was thoracolumbar scoliosis in a significant number of patients. I call your attention to the fact that one should always look at the countdown from T12, because we found lumbarization of S1 in 11% of children and 7% of adults. These patients were predominantly, the conus was positioned at or above L2. Only a small percentage of patients was the conus descended below L2-3. There was a significant incidence of neurogenic bladder with positive urodynamic testing in both age groups. And I'd also call your attention to the fact that there were a significant number of these patients had been referred for failed Chiari surgery in the past, even though they had normal posterior cranial fossas that were determined to be present later, and cerebellar prolapse was a significant problem. In general, if the Chiari symptoms predominated and the herniation was at C1 or below, we would do a posterior fossa decompression on these patients. Only in the patients with minimal tonsillar herniation were we looking at treating the tethered cord first. And this is what we see at operation. This is through an L4 laminectomy, simple L4 laminectomy. And this is the phylum. It is dorsally positioned with the patient in the prone position. There is almost no movement of the phylum with respirations or systole, and it can be seen through a greatly thinned out dorsal dural membrane, almost as if it had been worn thin over time. That's the general appearance that we see with the occult tethered cord. It's a different matter with the traditional cord tethering. And when we do intraoperative ultrasonography, it can be recognized here in the axial view as a structure positioned immediately beneath the dorsal dura. In general, the caudal equina nerve roots tend to be packed laterally. And on lateral view, this is the phylum. This vast empty space is because it's a sagittal view. And after sectioning, we would get a redistribution of the nerve roots, and we would get the phylum would fall from its dorsal position. It would fall limply into the ventral subarachnoid space. This is the same situation. I showed you a thicker phylum so it could be seen, but this is more like it. The average phylum in this group of patients was a mean of 0.7 millimeters, less than a millimeter in thickness. Can't even be seen on the sagittal view, and I think when you put this kind of imaging together with this is something that cannot be recognized by the resolution of modern-day MRI. The structure is too small, it's dorsally positioned, and it doesn't have a signal for fat. So the question everybody would like to know, is the phylum dorsally positioned or ventrally positioned, cannot be determined by intraoperative MRI, by MRI. We can see it with intraoperative ultrasonography. And we also can detect, after sectioning the phylum, the nerve roots redistribute and CSF flow improves. I'll just show you a little short run. This is a 32-year-old woman with a Chiari and tethered cord, and you can appreciate the structure up here, which is the phylum. The lateral packing of the tonsils is seen here. Here are the nerve roots. You can see maybe a little glimpse of the phylum coming into view. When we measured CSF flow in the dorsal subarachnoid space and the ventral subarachnoid space, it was virtually zero. After sectioning the phylum and sewing up the dura, you can see the redistribution, even distribution of the nerve roots. I think you can see the dropped limp phylum. The ends tended to retract very briskly after they were cut. They would snap and retract briskly. And after surgery, one can see very vigorous CSF flow, not only dorsally, ventrally, but between individual nerve roots of the caudal equina. Good high flow, which meets the criteria. Those are kind of the findings that we see intraoperatively. When we put the color Doppler data together, the separation of the distraction of the cut ends of the phylum was pretty significant, in the order of 35 millimeters in children and 40 millimeters in adults. That's 4 centimeters. What we also did was get a mean measurement of the phylum diameter in this age group, and it was rather small and thin. The section of the phylum terminale resulted in the following changes that we were able to measure. On post-operative MRI, there was ascent of the normally positioned conus in patients with a normal conus position, but they were measured by Dr. Nishikawa's follow-up MRIs. There was ascent of the conus medullaris from a normal position to a higher normal position. The brainstem length, which was invariably enlarged in this group, reduced in all individuals, and generally normalized within 6 months after surgery. The medullary height, which was pulled down, restored itself and ascended, and the cerebellar tonsils went up. But this is on a large a group of patients, and these are mean values. The height of the fourth ventricle displaced below Twining's line, also elevated. This is what would be seen, but it might be hard unless you did measurements for minimal tonsillar herniation to really be sure about these things. But the measurements that are used, the brainstem length, go from the ponto-mesencephalic junction down to the caudal apex of the gracilis tubercle. That's how the brainstem is measured. And the fourth ventricle is measured from Twining's line to the posterior aspect of the fourth ventricle. Tonsillar herniation is measured in the standard way. And in this patient, an 18-year-old female, the brainstem was long, the medulla was pulled down, the fourth ventricle was downwardly displaced, and tonsillar herniation was 8.1 millimeters. This was 3 months after surgery, and there have been some improvements. The length of the brainstem has decreased to within normal limits of 52.8 millimeters. There's been ascent of the fourth ventricle and the brainstem, and the tonsillar herniation, while still present, has been reduced. Now, I'm not going to just show you a series of anecdotal cases, but I think it's worth demonstrating a few. This is an example of a 27-year-old woman who was a candidate for posterior fossa decompression, but she more or less had a choice. We told her that her posterior fossa size and volume was normal. We did feel strongly that she had a tethered cord because her brainstem length was significantly increased, and she had a very wide foramen magnum. So she opted for the section of the foramen terminale, which we did. And at 7 months later, you can see this is quite dramatic. The tonsillar herniation at C1 and now at the level of the foramen magnum. I think that any anecdotes that I give you or that you hear in meetings like this have to be taken on face value, because there are rare examples of spontaneous resolution of syrinxes and chiari and so forth. But this is something that we've seen over and over and over again, and this analysis that I gave you is based on mean values in 318 patients. So it was confirmed in that fashion. Here's a patient who came in, who's a little girl, 8-year-old, who had an operation for Chiari, and she was all right for a while, but then the symptoms came back, and she developed a increasing, enlarging syrinx. Now, a few years ago, I know exactly what to do for this patient. I would have taken her back, enlarged her craniectomy, taken some pericranium, giving her a very generous duroplasty, and probably shrunk her tonsils by polar coagulation back up into the head. But because she had elongation of the brainstem, downward displacement of the brainstem, we decided to do the tethered cord. And the section just 5 weeks after surgery shows, you can see the re-expansion of the subarachnoid spaces, both premedullary cistern and subarachnoid spaces. These are measurements by Dr. Nishikawa, which shows some ascent, maybe 4 millimeters or so of the tonsils back in the head. And one of the consequences of this was that the syrinx was significantly collapsed as a consequence of one simple measure, which was section of the foramen terminale, not posterior fossa revision. I'm going to take these a little out of order. We see, we've defined terminal syrinxes as syrinxes that occur in isolation, unassociated with syrinxes above that level from T5 down. Most of them are at terminal level at the end of the cord, but occasionally we'll see syrinx that looks like this. And we've had fairly good success, as I'll show you in the summation, the data, with terminal syringomyelia being resolved, or at least improved by section of the foramen terminale. Now, this is a case I alluded to this morning of a patient who had a standard Chiari decompression with some improvement for several months. It was done by an absolutely outstanding American neurosurgeon, one of the best there is. And the symptoms came back, and the cerebellum slumped down. And ultimately, a cranioplasty plate was put to try to give a little bracing for the tonsil, but it did not work. And when the patient came to our attention, there was obvious elongation of the brainstem. I don't have this particular patient's measurements, but you can see this very long brainstem. You can compare it with your eyes before and after section of the foramen terminale. And there was this ptotic cerebellum, more than just slumped down. The shape of the cerebellum looks like an Idaho potato that's just fallen through a hole in the floor. And after section of the foramen terminale in this patient, 8 months later, you can see that the cerebellum has remodeled itself. It has ascended back into the posterior cranial fossa, and you can also see, I think, without clear measurements, that the brainstem length has reduced and is now normal. So this was an eye-opener for us because we saw a subset of patients with failed Chiari surgery, and for cerebellotosis or for cerebellar hernia, where there is herniation of the tonsil out through the craniectomy opening. In a patient with tethered cord syndrome, in our opinion, based on a pretty sizable experience, the treatment of choice for that patient is section of the foramen terminale. Now, I'm going to get to the controversies, but I'm going to just summarize the findings here. In both infants and children, the complication rate of section of the foramen terminale was quite low. I think some of you have traveled to New York and seen the way we close this ultra-thin dura, can see why we have a very low incidence of CSF leak. It requires a extradural outer layer suturing technique, just a few fibers, often reinforced with a patch of muscle and then covered with a blood patch, and tested in extreme reverse Trendelenburg position with a series of forceful Valsalvo maneuvers at 40 torr. And not until it's absolutely dry that we assure ourselves that we've probably got a good closure. We got improved symptoms, and this is just a generic combination of the Chiari symptoms and the tethered cord syndromes as reported by the patients. There's data here based on pre- and post-operative urodynamic testing. These are improvements that were witnessed. And again, a neurogenic bladder can have many causes. And to try to expect that it is a pathognomonic sign of tethered cord syndrome, whether classical type or occult, is wrong, especially in women, especially in middle-aged women, where there are many different causes for neurogenic bladder. But you have to take, I think, at this point, because we don't have any precise criteria, except for this combination, which I'll repeat once again, of a patient with a Chiari, but a completely normal posterior cranial fossa in terms of size and volume, a large foramen magnum, an elongated brainstem, and a downwardly displaced cerebellum. That, at this point, makes us quite confident we're talking about the correct diagnosis. We had respectable, this information should be out online probably in a few weeks. So I won't go into it in detail because I think the controversies are probably more interesting than just going through the data. But the reduction in size, resolution was kind of rare for terminal syrinxes, but they remained stable or had changed, got better. Same thing with cervical thoracic syringomyelia. We had a very low incidence factor, 0 incidence of complete resolution of the syrinxes, but the syrinxes were smaller in 60% of children and 27% of adults, and the same went for holochord syringomyelia. There was some improvement in thoracolumbar scoliosis, but the issue that is, I think I should call to your attention is this is a short follow-up period, and none of this information has great weight until we have been able to confirm it and repeat it and look at it over a longer period of time. And that's just what we intend to do. But the early results, and that's why we termed it the preliminary results, suggest that we're dealing with a very interesting new condition. We're seeing a lot of it. They meet those criteria, and there can be benefits to these patients and there can be avoidance in some cases of the need to produce a posterior cranial fossa. All right, so what's the controversy here? I think the contradiction that's obvious from the things I've just shown you is the presumed mechanism is some sort of downward traction on the spinal cord. And you've heard some of the literature that's been published, cadaver models, animal models. Of course, one has to weigh whether those are particularly comparable to the human model. And there's been controversy going on since 1932 about whether there's traction with Chiari malformation 2, myelomeningocele, or there isn't. And that controversy will probably go on for a while. But the question that people ask is, how can this possibly be tethered cord contributing to tonsillar descent if the conus medullaris is normally positioned? And that's a question we don't have an answer to. I'm simply showing you our observations, and I'm not intending to make conclusions or even to create a hypothesis for this. The working hypothesis of our group is that, first and foremost, this combination of tethered cord syndrome and Chiari has something to do with some pathological type of phylum terminality, whether it's too fibrous or too thick, and eventually becomes pulled. We're not sure. But the working proposition is that there's downward displacement and that the guilty party is the phylum terminality. Now, if the phylum terminality starts off as thick and inelastic, then we will have a conus disanchored low, below L2-3. Those are the ones we can recognize today. Those are the ones that constitute the classical tethered cord syndrome. Those are the ones that the MRI can see. The ones that we're talking about, the MRI cannot see, cannot identify the phylum. Our presumption is that if the phylum terminality is intrinsically tight from whatever pathological feature or features it might have, but it has some degree of elasticity, that is able to stretch with somatic growth. So you could start off with a tight phylum. If you had a bell-shaped curve, the really thick ones that are rope-like thick will anchor the cord down at a low level. But if there's some elasticity, the phylum is able to stretch with somatic growth, which allows the conus to ascend to a, quote, normal position while maintaining some degree of pathological tension. Now, we don't have any proof at all for that. And we're talking because one has to come up with some sort of a potential hypothesis to explain it. But this might speak to a continuum of pathological phylum. Those that are very thick, very tight, that don't permit the conus to ascend, and others that can stretch over time, but that maintain tension. We have a series of engineers in New York working on devices, tonometers, to try to measure the phylum, but I'm skeptical that that will work out. Now, what's the best evidence that we have for this hypothesis? That you have a phylum that can stretch, the conus can even go into a normal position, therefore it becomes occult. It can't be seen with the MRI because it's thin, but it still has tension. Well, I think the intraoperative findings are consistent with that. We can see that the phylum is uniformly thin, it's taut and dorsally positioned, even if the patient's in the prone position. Second, we observed over time with teledoppler ultrasonography reduced movement of the cauda equina, lateral packing of the nerve roots, as if something was just pulling the whole group of structures down with it. After sectioning, and I think some of you who have been to New York have seen the snap. You've seen that little thin, tight phylum cut and snap, just like a rubber band after it's been pulled and then divided. It retracts briskly. In this group, the mean separation of the distracted ends as measured by Dr. Bolognese with the teledoppler ultrasound was 4.5 centimeters. And immediately afterwards, you could see, and you could see it today, the redistribution of the nerve roots and the increased pulsations in the cauda equina, and we have measurements to indicate increased flow. Now, as far as the postoperative findings, to be consistent with this hypothesis, the conus ascends above its quote normal position to a higher normal position. And the mean distance is somewhere in the range of 5 millimeters at 5 months. This is accompanied by a reduction of brainstem length by almost the same extent. The mean reduction of the length, elongation of the brainstem is reduced by about 5 millimeters at 5 months. And with it, the tonsils ascend, again by about 4 to 5 millimeters at that period of time. And that's where we stand now. We're looking very carefully at this, and our paper on this subject is meant to be preliminary. And I want to urge that we're staying away from conclusions. These are just the observations we've made. But I will say this. When we have a patient with a Chiari who's got a normal posterior cranial fossa, someone will have to tell us all how are the tonsils descended, on what basis could they be descended. And when we find that they have an enlarged foramen magnum to go with it, and the brainstem is elongated and downwardly displaced, there needs to be some way to put that all together. From what we see now, there is a connection between a disordered pathological fiber, thin but taut, and this phenomenon of brainstem descent, elongation, enlargement of the foramen magnum, and the Chiari. And when we section the filum terminale, the results have been good. What our conclusions would be, they're very soft conclusions, is that this tethered cord syndrome, whether it's classical or occult, is a causal mechanism in some cases for cerebellar tonsil herniation, not the cause of Chiari. Millhorat didn't say that. He said that it is one causal mechanism that can be associated with downward displacement of the tonsils. And the problem right now in the diagnostic distinctions of Chiari-1 and tethered cord that really stand out is the absence of posterior cranial fossa hypoplasia. Someone will have to come up with a better explanation of why there is Chiari herniation in that circumstance, and why there is elongation and downward displacement of the brainstem and cerebellum, and why there's enlargement of the foramen magnum. Our preliminary surgical experience is that the tethered cord sectioning is comparatively simple. All operations have their problems, and this is no exception. But compared to posterior fossa exploration, internal duroplasty procedures, tonsillar shrinkage and the like, this is a lower level of operative risk. When we perform section of the filum terminale as the initial operative procedure, and that's in the select group that I mentioned to you, these are patients with cerebellar tonsils at or above C1, not all the way down. And the posterior fossa decompression to date was avoided in a significant number of patients, 78% of that small group of patients, followed up for a very short period of time, 6 to 27 months. And therein lies the uncertainty. We simply have to see how this happens over the long haul. Have avoided the posterior fossa decompression. In patients with failed Chiari surgery, in which the major problem is cerebellar ptosis, or cerebellar hernia formation, we found section of the filum terminale to be the optimal treatment. I've spent many years putting on cranioplasty plates to try to contain this problem. We've gone back in, opened up, and tried to shrink the already slumped tonsils. And I can tell you from my own failures with that procedure, it is usually done in vain. It does not work. But we were really astonished to see in these cases that we've reported with postoperative cerebellar ptosis how the tonsils not only go up, but the cerebellum reshapes itself. So we think that it's the optimal treatment for cerebellar ptosis complicating Chiari-1 surgery, and by that, probably Chiari-2 surgery, and that we are going very, very carefully at indications for when to do the standard Chiari operation. All those patients would be candidates for Chiari-1 operations. They all met our surgical criteria to have posterior fossa the decompressions. And we're going to have to see how we change it. We do not have an exact plan. We've just taken herniation to C1 as our sort of starting point, and that may change. But what I wanted to leave you with today is just these observations. I want to emphasize that when we speak of Chiari, we're speaking of a radiographic diagnosis of tonsillar herniation and nothing more. We're not saying anything about the specific mechanism of cerebellar tonsillar herniation, which after all is probably the most important feature of the Chiari one. And hopefully, as we look at them more carefully in the future, and maybe our colleagues neuroradiologists can help us in segregating those with normal posterior fossils from those with small posterior fossils and so forth, we'll be able to address these problems on a case-by-case basis in a manner that we and that I personally have been able to manage them in the past. So thank you very much.